Okay, good afternoon and welcome. As I mentioned, we are now live streaming on Facebook. And welcome to our presentation on biomarkers, precision medicine in cancer care. I am Erica Narducci, the program director here at Cancer Support Community Delaware. If you're new to us, welcome. If you've been here for many years as a participant, welcome to you as well. So, we provide no cost support to cancer patients and their family members in the form of support groups, healthy lifestyle classes, and education. So, today you're here for some great education with Darcy Burbage. I've had the pleasure of knowing Darcy since I began my position here. She has been an oncology nurse for over 30 years. She worked at Helen Graham for many years. She currently does contract work with the Oncology Nursing Society and is an adjunct with Duke University's School of Nursing. And has a much longer bio, but that's just kind of a little synopsis of how amazing Darcy is. So I am going to turn it over to you, Darcy.
Great. Thank you. Thanks, Erica. Nice to see all of you. It's always a pleasure of mine to speak with the participants of the cancer support community. We're going to talk about some exciting advancements in cancer care. Not new necessarily, but we're learning more and more every day about the importance of precision medicine and cancer care and, tailoring the treatment to not only the person, but also the specific cancer that the individual has. Oops, oops. Let me see here. Oh, here we go. When I began my oncology nursing career many years ago, um, most chemotherapy was given in the inpatient setting, meaning the hospital setting. And if individuals had a particular type of cancer, I pretty much knew what type of chemotherapy treatments may be prescribed or given to them. Precision oncology, however, is exciting because it's all about giving you, the individual with cancer, the right testing and the right treatment at the right time. So we've come a long way. One of the ways that we do this is through the use of genomics and understanding the genes that are in our tumor. And if they're altered somehow, how this is causing the cancer to grow. And then once we find out a little bit about the alteration or variant, hopefully there is a targeted treatment that can be offered to help stop it from dividing. There's a lot of variants that have been identified, which are called biomarkers, and certain ones of them are actionable. And we'll talk a little bit about what that actionable means. So, in other words, not all cancers of a particular type are caused by the same genomic alteration, which means that the treatment for someone with colon cancer may be totally different than the treatment that someone that may be sitting next to you in the infusion center is getting for colon cancer. So before we talk more about biomarkers, I just wanted to spend a few moments discussing the difference between genetics and genomics. Um, Genetic variants are inherited, meaning they are passed down from parent to child, and the change is in every cell in the body, and it accounts for approximately 10% of cancers. Genomics, on the other hand, is considered an acquired or a somatic variant, meaning the change is developed over time and it's only in the tumor itself. So, if your oncologist is discussing tumor testing with you, they are discussing testing your tumor for one of these acquired or somatic variants. So, a large part of precision medicine, precision oncology is biomarker testing. And each cancer has its unique set or pattern of biomarkers. Precision medicine means using tests to select treatments that are most likely to help you, but at the same time, sparing you from getting treatment that are may not be likely to help. Targeted therapies, immunotherapies, things called androgen deprivation therapy, if you've heard of that, if you've had prostate cancer, or estrogen reducing therapies, if you've had breast cancer, are different types of targeted therapies that are prescribed for individuals who have these different biomarkers. In some cases, somatic testing may identify possible germline variants that are associated with hereditary cancer. So, if that occurs, you may be referred to a genetics counselor. There are many different types of biomarkers, and different types are appropriate for different individuals and different circumstances. So, because of this, when to test and how frequency to test differs by the type of cancer. Because biomarkers are used for different purposes, testing may occur at different times during the continuum of care. Sometimes at the beginning of treatment, um, throughout therapy to see if you may be responding or not, or if they suspect that a cancer has recurred or that you may have developed advanced or metastatic disease to see if there's a different type of therapy that may be available. And some, not to muddy the waters, but healthcare is like that in some cases. Some biomarkers have more than one indication or role. For example, HER2 in breast cancer can be diagnostic, predictive, as well as prognostic. So it has a couple different factors to that. So those are some things that your oncologist is looking at if they ordered testing and they're looking through the results and discussing the results with you. One of the most commonly used techniques for biomarker testing is called next generation sequencing. Sometimes it's abbreviated as NGS. It may also be called tumor profiling, tumor testing. Sometimes you'll hear these words interchangeably. Molecular testing, genomic profiling, companion testing. NGS testing or sequencing, it allows us to test for many different biomarkers at the same time. So it's the most comprehensive, fastest, and cost effective. However, fast for NGS testing can take up to 2 to 3 weeks, which sounds like a long time. And it is a long time when you're waiting for test results to determine what the next treatment or therapy would be. However, if your doctor feels that it's important to wait in order to get this information and before recommending a treatment plan, um, it's good to wait to do so. As there's, as I talked earlier, there used to be, there's many different options of chemotherapy, but with the targeted therapies, we're looking at how we can individualize the treatment for you. Immunotherapies, targeted therapies, they have side effects. They're different side effects than chemotherapy. Um, I know I've heard from other patients I've taken care of that, oh, there's no side effects. There's different side effects, but I wish there was none. But unfortunately, that's still the case. So we're still getting there. So, what are biomarkers? So, biomarkers confirm if the cancer has a specific um, variant that can inform treatment decisions, and they use a sample of your cancer cells, and it's sent to a special lab for analysis. It also may identify biomarkers that help the treatment team understand different things about your type of cancer. As I mentioned before, there's different types of biomarkers. So if it's a predictive or a prognostic biomarker, it also may detect variants of unknown significance or changes where the risk is unclear. So we don't know what that means yet. So those are some things that may have to be taken into consideration as well. It may also show that there's no biomarkers identified, or there may not be any actionable targeted therapy. So, if that's the case, rest assured there are evidence based treatment guidelines that your physician will review with you in regards to treatments that are available. Just like the name says, targeted therapy are treatments that target different cancer or specific cancer subtypes. Um, as I mentioned, if you have an ERPR positive breast cancer, more than likely you may have been recommended some anti-estrogen therapy to help treat that type of cancer. And the opposite is also true. If it was estrogen receptor negative, more than likely you won't be prescribed an anti-estrogen therapy as it's found not to be effective in that subtype of cancer. However, there are some limitations to biomarker testing. For one, there may not be enough tumor tissue to test for biomarkers. The test may not find any biomarkers in your cancer that would match with any available treatment. The test may identify a therapy that's being tested in a different clinical trial that's not open to someone with your particular type of cancer. Sometimes it finds a biomarker that matches a treatment, but for whatever reason, the treatment doesn't work. I know we've come a long way in cancer care, but we're not there yet. We're not at a cure yet, as much as I wish. And I know everybody that is on the call and that I work with in oncology care, we wish we were at that cure point. And also, sometimes the cost can be pretty prohibitive. It can be thousands of dollars for biomarker testing. Sometimes insurances are a little tricky, so we may need to manage them, talk with getting authorization. So there's a lot of different, variables. So hopefully, the more we know, the more we learn, we'll get better at covering all of this for individuals who need biomarker testing. So what I want to show you here, I know it looks really confusing and I apologize for this, but I think it's important that you know this information. This is an example of what a biomarker test may look like. It's different than a pathology report. This is an example of NGS or next generation sequencing for someone who has lung cancer. And I'll go through each of the letters on here so you can understand what that means. In the A section, it identifies if there's an actionable variant or not. In this case, the individual with lung cancer, it was found that their lung cancer had an EGFR variant identified. B is classification. The variants are classified into four different tiers. Tier one are pathogenic in nature and likely associated with an FDA approved therapy. So if you can see the C, um, for this individual, EGFR was amplified and osimeride or Tagrisso has been identified as an approved therapy for from the FDA for someone with lung cancer that has EGFR. So that may be a recommended treatment for them. For this individual, D is therapies are likely not to be effective. So the following treatments have not been found to be effective in this person that has the EGFR identified lung cancer. And they look at therapies in different types. So according to this record, it hasn't been found at this time that Tagrisso is effective in others. And potential clinical trials, these are clinical trials at this time all over the world that may be potential eligibility. So it looks like there's about 60 clinical trials at that time. Um, and then as we go further down, different therapy biomarkers, MSI, tumor mutational um, burdens, looks at what type of actionability based on what this person had. And at this time, there were no therapies or clinical trials available. Also, it looks at any prognostic or diagnostic variants. In this individual, TP53, which is another biomarker, um, is associated with different cancer types and what the clinical outcome could possibly be. So these are some things that the doctors are looking at when they sit down with you to go over um, the next generation sequencing or tumor testing results. And it gets better. It's longer than that. So that's much more further information. So may identify the percentage of sequencing where the variance was detected. So in I, almost 50% or 49% what occurred in this particular instance. Um, and as I mentioned too, that genomic variants may be detected on tumor testing that they may want to follow up with germline testing for individuals. This person in particular, they recommend to follow up with germline testing. So that's the genetic testing. So that's something else that may be offered or considered when you have NGS sequencing done. And also, which I find a little always like, oh no, the variants of unknown significance. So what does this mean? So we don't know what it means at this time. So that's something that we need to, they call out on the report. So perhaps in the future, they'll be able to identify what significance, if any, this particular additional biomarkers have for this particular individual. And also the genes tested. The labs will perform all genes, and within the report, sometimes there's 20, sometimes there's several hundred that they're able to test for. So the report could look much longer than this 2-page report that I'm showing you, depending on how many markers that they tested for and identified. So NGS sequencing, as I said, it's the most comprehensive. So sometimes this is pages and pages that individuals the doctors go through and look at and discuss with you in regards to what's next and the type of treatment that they may recommend. And this goes into a little bit more detail of the clinical trials. So, for example, the phase studies. So this goes into, what EGR amplification and what exactly the drugs are that they're testing, or the different routines that they're testing it. Maybe they're looking at, do we give it weekly? Do we give it every other week? Do we give it, more frequently or less frequently? So there's many different clinical trials that are available for this particular EGFR amplified lung cancer for this individual who had the NGS sequencing. So there's a lot to consider. So a lot of information that's available in these reports. And it takes a lot of time to understand it and surf through it and get the recommended treatment for you, that to make sure that we're giving you the best treatment possible that's available.
Darcy, before you go to the next slide, let me just, a question came in the chat about, does the percentage of marker make a difference, or is it just significant that it's there?
Um, for the I section, I'm guessing. So it's just something that they test. So it doesn't say if it was like 1% or 50%. It's just what they found. So it's not like if it's worse or better, if that's the question. I'm not sure, but it's just what it was identified as.
Can I ask that? I'm the person who asked that. Can I just ask a follow-up?
Yeah.
I mean, I just wonder, like, I had some testing done and I for a lot of stuff, and there's all sorts of percentages. And I just wonder though, does it matter the number of the percentage, or it's more just that it's present, like that matters, that when you like if it's something they do know about, um like a lot of things they don't really know how that would inform anything yet, but let's say it's something they do know, does the percentage of it matter, or is it more just that it exists in you?
From my understanding, it's just that it exists. Um, so I don't know any more detail than that. That could change over time too, as we know more information. Um, and I'll go back to just something different. I used to work with, individuals that have breast cancer most frequently, and if their ER/PR percentage was low, and then there was individuals where it was higher, we just knew it was positive, so that why treatment was recommended. So it may change over time, we just know if it's present or not. Is that helpful or not helpful?
Oh, yes, it's helpful. I just was curious because
Sure.
they're very hard to read. Like,
Yes.
I've never seen a report like this. I just saw a long list on my medical thing, but I
Yeah.
never saw something where it goes on to like different trials or prognosis or anything of those things. I never saw something like that.
Yeah. Thank you. Mm, I'll just, so the next slide, I just wanted to, summarize and we can take more questions. It has really been a game changer in certain circumstances and really contributions to cancer care. But not only here in cancer, but they're also doing biomarker testing in other conditions such as Alzheimer's, different types of arthritis, autoimmune conditions, other neurological conditions as well. Um, so we really need to be able to, test as many people that are eligible to identify more research so we can identify more biomarkers and targeted therapies. There's individuals that have biomarkers and we don't have a targeted therapy for that particular biomarker yet. But when you're that person that doesn't have it yet, there are options available, but they're doing research all the time. Recently, something just came out from with ALL, and there was something in non-small cell lung cancer. So I know that they're always doing research, but not quick enough. I wish it was quicker. And also, if there's an ability that anyone has just to, advocate for insurance coverage to everyone that's eligible, because it can cost thousands of dollars for, um, biomarker testing. And depending on your coverage, my goodness, you may have to pay a percentage or all. So, um, there are, advocacy organizations, the American Cancer Society, for one, that is looking at advocating for more insurance coverage for biomarker testing to everyone that's eligible to receive it. And it's either the references that I used. So American Cancer Society, National Cancer Institute. I do a lot of work, as Erica mentioned, with the Oncology Nursing Society, doing biomarkers and, putting in resources together for oncology nurses so they're up to date on all this information as well. But, the ACS, NCI, if you want more information, they update it as information becomes available. And also your treatment team, talk to your oncologist if you have questions or, more details, if you want more information, because I know how it is to go in and you're like overwhelmed and having that report in front of you. So that's what they're there for. We're all there for, is to help you. And I just want to thank you for your time. And I know St. Patty's Day is coming, but if there's any questions, I'm open to taking them. So hopefully I can answer them for you. So
I had a quick